What's up, everybody? This is Dr. Bonzo here on the License to Live podcast with my good friend, Dr. Jarrett.
Welcome to the Licensed to Live show, where professionals, doctors, champions, VIPs, attorneys, and those in public office discover strategies that help you restart and gain what is lost when you find yourself accused. If another has doubted your integrity, questioned your credentials, or caused your actions to come under scrutiny, you are in the right place. On the other hand, if you have never felt the knot in the pit of your stomach when legal papers are served, the heartbreak of disappointing your family when the lock clicks shut on handcuffs, or had to appear before a board of review, then be aware, the longer you serve, the more likely you are to find yourself under the microscope of those who judge. Prepare yourself for this uncomfortable possibility. Now, here's your host, Dr. Jarrett Patton.
Welcome to episode 180 of License to Live. My name is Dr. Jarrett Patton, and I'm your host for our journey together today and every day you choose to listen to this show. If you or anyone you know has been dissed in their career, please invite them to join us along this journey. Just go to Apple Podcasts, Google Podcasts, iHeartRadio, wherever you listen to your podcasts, and subscribe to License to Live. And while you're there, please rate this episode and give me honest feedback so I make sure I provide you with the most up-to-date information about career challenges and life changes. And today, folks, you don't want to miss our special guest here today. I mean, he's been an esteemed academic clinician. He has a number of special interests that have really propelled and excelled his career. And most importantly, he has a new book that I can't wait to talk about with you today. So you guys have to hang on, listen to the wisdom and the words that he is going to deliver to you in this show. And we're going to get started with our conversation right after we finish thanking our sponsors.
Something smells good. EH3 coffee. EH3 coffee. Premium organic. Nothing better than waking up. EH3 in your cup. Premium organic. EH3 coffee. Nothing better than in the middle of your day. EH3 coffee. Premium organic. EH3 coffee.
Hey guys, this is Janae Noonan, and I'm here with Dr. Jarrett on License to Live. Hit the subscribe, follow the journey. Let's go.
Hey, this is Dr. Jarrett Patton. Do you need more positivity in your life? No matter what part of your life you want to transform, positive affirmations can help you achieve your goals. But sometimes making permanent changes can be difficult. Designed with you in mind, License to Live. Daily affirmations to rebuild your life will inspire and equip you to become the best version of yourself. License to Live. Daily affirmations to rebuild your life will set you on the path to changing your mindset, beliefs, speech, and ultimately your actions. You can change your life now by getting your copy at Amazon, Barnes & Noble, your finer book retails, or licensedtolive.com. That's licensedtolive.com. Yeah, and if you want to turn your life around for 2024, you are looking for more positivity, you are looking for a change, start with affirmations. You will start with these affirmations, and what you will learn is your mind will continually transform. Not only do these become, statements that you have for yourself, you see them, you believe them, and guess what? They manifest into your life in order to provide you with the future, the life, and the career that you're looking for. So go to licensedtolive.com. Well, today, folks, all you fire starters out there, we have a very, very, very special guest who's coming on the air today with us. And he has been very well known in public health circles for a number of years. This man has been the chair of community medicine at Mercer. He has written countless research articles. He has gotten literally countless academic teaching awards over his tenure. And he has even most recently taken a position with the Georgia Department of Public Health. And he is now the DPH District Director of the coastal region in Georgia, which actually encompasses some of that southeast area. So you're looking at Savannah and a number of all the coastal districts. And he has taken a little bit of time out of his schedule today so that we can talk about some of the new things he's going on in his life and his new book. So I am welcoming a good friend, a good colleague, Dr. Bonzo Reddick, to License to Live today. Welcome, Dr. Bonzo.
Thank you so much for having me, Dr. Jarrett.
Well, I've been waiting for this day for so long. I've known you for a number of years. I followed your work and the things that you have been able to do over your career. And I really got to get into that discussion in a minute. But knowing all of these great accomplishments that you've done, pretty much anywhere you have put your imprint, and your imprint obviously is in Georgia, around the town where you've grown up and lived, in Savannah, Georgia. In fact, I remember very recently, well, it seems like it's very recently, but it's probably a couple of years ago, my travels took me down to Savannah, and you gave me the best windshield tour of a city that I've ever been given before. And particularly, I remember you driving me down on one particular side of town. We parked next to a chain link fence. There was all this brush, overgrown. It was underneath, an overpass. And you told me a story about some of the population that you take care of, and you are a doctor for the homeless. And you told me about some of the programs that you've started in order to reduce harm for people in the greater Savannah region. But particularly, you told me the story about a syringe that I can't forget. So rather than me try to retell this story, I've got to let everybody know what kind of physician you are. Yeah, I mean, so if you guys want to know, Dr. Bonzo's a family physician. You know, he studied at esteemed institutions like Morehouse, like University of North Carolina, and he wound back up in his hometown, practicing medicine, doing all the things that he always wanted, taking care of his community, when he told me about this syringe. So, Dr. Bonzo, I got to let you take it away from here.
For the past 7 years or so, my clinical practice outpatient has been with a federally qualified health center. A lot of people know that as an FQHC, but it also has a federal designation as a healthcare for the homeless site, or an HCH site. So we don't just do care for people experiencing homelessness in the clinic building. We actually provide mobile services as well. One of the things that is very common in people who are unhoused or who are experiencing homelessness is difficulty with transportation and access to care. So for the things that we can take care of outside of the building, we go to them. So each week we have a mobile homeless clinic that pretty much rotates around in our catchment area. So if you kind of look at the area we serve, there's about 5 or 6 different locations that are relatively central to those areas. So things like soup kitchens or shelters or places like that where people actually come and we receive care. We have a mobile unit we set up there. So one of the sites that we serve is the one that you went to, which is actually a site underneath a bridge. That homeless camp actually has since then been dispersed, but so it's actually not there anymore. But it was one of our kind of highest impact areas, I guess, in terms of the volume of people we serve, but also in terms of how many issues they were dealing with. So the rates of IV drug use in that community were very, very, very high. Just coincidentally, there was an actual documentary that was done about the opioid epidemic on PBS that actually won an Emmy and actually featured our clinic at that site. But it's because the kind of things you see during the care there. Our medical students that rotate with us, they often were really kind of taken aback. You might see somebody in broad daylight injecting drugs. And so we were kind of used to that. We follow a harm reduction attitude towards things, but the day that really just did it for me was we're walking across and seeing somebody who was trying to crawl into the ditch that kind of leads into that homeless encampment. And it's an area where people use needles and they just kind of chuck them into the ditch. And so we saw a patient kind of climbing down into the ditch, trying to get an old use and syringe and needle so they could inject drugs. And that was a day where it really stuck out to me, where I said, there is probably nothing I can say or do with this person right now to make them not use drugs today. But what I would like to do is make sure that they don't, contract HIV infection or acquire hepatitis C infection or develop bacterial endocarditis from injecting with that dirty needle. So those are kind of the things that we focus on. And I'd heard about harm reduction. We kind of say we do harm reduction with things like pre-exposure prophylaxis for HIV or condom distribution. But needle syringe exchanges really, really became something I was interested in from that day. The students that were with us were really bothered by it. One of our nurses was actually the one who first noticed it and said, please don't do that. Like, I have some clean insulin syringes I can give you. And it turned out that our nurse had actually been giving out some clean syringes for a while. I just didn't know about it. Needle syringe exchange, syringe services programs were legalized, I believe, in 2017 in Georgia. So it's something that people are doing kind of here and there, but it wasn't really organized. So anytime somebody either expresses doubt about harm reduction or syringe services program or needle exchange programs, I often tell that, I often tell that story whenever somebody expresses a little doubt about the exchange programs, because, people say, oh, you're enabling drug use, you're enabling bad behavior. But that day and that image of somebody saying, yeah, I know that needle is down in some dirty ditch water, but I need it really bad to use drugs today. I'm going to climb in there and use it, knowing the risk of it. So, and just because you were in town, I can tell that story. That story really tugs at people's heartstrings when they hear that. But actually seeing that ditch and what it looked like, you actually seeing it and saying, I think it adds another level of just wow to that story. So that's why.
Because I certainly wouldn't even want to be walking in that ditch, let alone drinking water out of that ditch, or let alone injecting something in me that came out of that ditch.
Yeah. But that shows how drug dependence disorders really can get a hold of people if they're in a bad spot in life. And it's easy to judge people, but realizing that, wow, some people are really, really having things really hard right now. And either substance or their life circumstances gotten to the point where they don't feel like they have control on it. And that's the only way they can escape from life. And our role is to say, hey, we're going to try to get you help. We're going to offer substance abuse counseling to you and referral services, which some people take advantage of, but some people are not ready today to take advantage of. In that situation, we do harm reduction. We prevent HIV acquisition. We prevent hepatitis C acquisition. We prevent overdoses. We also give out things like naloxone to help reverse overdoses. So those are the kind of things we do. And that day we first saw that for the first time. And unfortunately, we've seen that happen more than once. But that first day it happened was the day it really switched for me and realized that a harm reduction attitude is really the approach to have and how important it was. And so, I mean, like I said, with you seeing that with your own eyes, it just adds a whole nother level to that story.
It absolutely does. And as I'm listening to this story again, it reminds me that you do have so many career interests, and public health must have been an interest of yours pretty early on, because you went to get your MPH pretty much right away as you were going through all of your training. And you developed this interest in healthcare for the homeless to, enhance care that you're delivering all across the greater Savannah area. And it provides care for a specific and unique population that you do take care and you continue to take care of today. So one of the big transitions that I know of your career that you actually went through is that transition from really being a heavyweight clinician where you're seeing patients in clinic, you're seeing patients in homeless camps, you're also teaching students and residents and coming up. And I mentioned the countless Teachers of the Year award you would get from your teaching and your academic prowess.
Sure.
And you've always angled some of your career at academic papers, so special interests you might write about, and you publish papers in the medical literature. Now, you go through all of these changes in your life, with being a heavy clinical doctor, with being a teacher, with being an administrator, being a chair of a department. But then you decided to take a complete career change, and you wanted to take your skills and your talents and gift to the Georgia Department of Public Health, where you currently work as a district director. And you end up having a lot less clinical time. So what was that decision about making this change in your career like for you, and saying, well, I'm a doctor, but I'm practicing medicine in a different way now?
Sure. So you kind of walked through, you actually kind of set it up perfectly, because that whole path that you described is really what led me to where I am right now. So I did do my MPH, my master's degree in public health, right after I finished residency. I know some people do it while they're in medical school or take a year off and do it, but I actually did mine over a period of time, over several years, actually. So I was working initially part-time and then full-time as a physician, and then going to grad school on the side. So the reason I did that initially was I started doing a little bit of volunteering here and there, doing some community outreach, health fairs, and community presentations about education on various topics. And I really started the master's degree just to get additional input about how to responsibly do community medicine and preventive medicine, public health, especially out in the community, not using communities inappropriately or doing things that aren't sustainable. So that was that. And I also wanted to get a little bit of extra experience with critical appraisal of medical literature. So I wanted to be able to know what was good evidence, what was good science, what wasn't. That was a big focus on what I was doing. And so in other words, so that I wouldn't just get swayed by any random person telling me, oh, you should use this prescription, or you should give this drug, or do this lab test. So that was the motivation for doing my MPH. But one of the electives I took was an introduction to health disparities. And that was the thing that was life-changing. Dr. Hogan at UNC was the instructor. And it just taught me all the different disparities that exist for different groups. And I'd heard about them, but it really moved the needle towards not just learning about, oh, Black patients have these worse outcomes, or gay patients have this worse outcome, or people living in rural communities have this outcome, but really what can you do about it from a broad public health standpoint? And that process led me to get an actual additional certification in interdisciplinary health disparities. And that just changed the entire lens with how I practice medicine. At that point, no matter what I was doing, it was always looking at, okay, what's the underlying problem here? Okay, what are the disparities that exist here? What social issues are at play here? How can I address not only what's going on with the patient, but also fix the underlying problem? How do I address this on a community standpoint? So everything I did over that previous 15 or so years of my career before switching up completely last year was really a public health focus. So there were a few years where I was the co-director of a teen pregnancy clinic. And so even with that, we were doing things like home visits. And we had this thing we called the Rocking Chair Project, where you can get these actual free rocking chairs for mothers who are breastfeeding. We actually had really high rates of breastfeeding, even in a teenage population, which isn't very common. So things like that, and going to do home visits, providing education. So everything I was doing, it was always like, okay, what's the next step? How do we fix the underlying problem? You mentioned about academics and some of the papers and grants. We had a grant, it was a little bit more than $1 million over about 4 years or so, doing HIV screening in emergency departments, which is a non-traditional setting, but that was meant to address the need that we need more HIV screening, but a lot of people don't have a PCP where they can go and get that screening done. So when they pop up in the emergency room and they get blood drawn, we go ahead and offer them the chance to get an HIV test right there. And then if they happen to be positive and have HIV infection, then we will actually refer them and link them, do linkage to care, essentially. And so even with that project, we were, excited to screen people for HIV, but we found out that a lot of our patients who tested negative still had high risk for acquiring HIV infection. And so as a result of that, what we started doing was developing PrEP services. There weren't very many people doing pre-exposure prophylaxis for HIV. And so everything I did essentially spiraled into something else. If you say, hey, Georgia has the highest incidence rate of HIV, we really need to screen more people for HIV, identify people early, get them linked to care, that'll decrease community viral loads. From there, it spawned into, well, who are the people we're not meeting? Well, the people who are coming in uninsured in the emergency room. All right, let's find a way to screen them. Okay, we're screening 15,000 people a year. We're identifying some people who are positive. What about the high risk negatives? Let's get them on PrEP. Okay, nobody in town is doing PrEP. Okay, we'll start doing PrEP at our clinic. I started 2 different PrEP clinics. So that sort of like, that's the public health mindset. And I started doing that just naturally over the last several years. Each year it got worse and worse, where for the first time in my career, I wasn't just seeing patients and interested in what was going on with them, but I was always thinking about, okay, what's the underlying problem? I really wish I could start this program. We should really talk to legislators and do this. And that's what public health, the DPH job, is all about. And so that whole process was just like, it was inevitable. You know, I mean, it was going to happen. It was starting to take over my life in every kind of way. And then it wasn't just doing healthcare for the homeless. It was also, okay, we're seeing high rates of drug use in this community. What can we do? Let's make sure people aren't overdosing. How do we get Narcan? Let's get a grant applied to get that done and distribute it. Okay, what are the barriers to distributing that? Let's talk about that. Let's write it up and share it with other people and see if they have ideas about how to overcome these barriers. Okay, what about risk of HIV and hepatitis C? Let's do some clean needle exchanges. Like, those are the things that happen. And public health mindset is always looking at not only just the individual person in front of you, but the community at large. And although I don't see hardly anywhere near as many patients as I used to see, because I have such a reduced clinical role, I am proud because I am supervising other people that are seeing patients, and we're making system changes that actually will address a lot of the issues that we see our patients plagued by. Sorry,
Fire starters,
but
that was right on time. That's right on time, Dr. Bonzo, because I want the fire starters to understand. I want them to know. I want them to hear you and say, listen, Dr. Bonzo had interest in healthcare for the homeless. He had interest for the community at large. He had interest in public health. He has interest in diversity, equity, and inclusion. And all of these things led you to making a change in your career pathway. And a lot of people struggle over the times when they are, not seeing patients anymore, and they don't want to see patients, or they can't see patients. And I know my own personal story. Going up the levels of executive leadership, I'm doing more and more meetings, more administration, more creating policies, more making changes that benefits healthcare for the masses. But I was seeing very few patients, and the patient numbers got less and less and less and less. And I started to feel guilty about that, because I said, I spent all this time as a doctor trying to be training, trying to do this. And now I'm not even being a doctor like everybody else thinks a doctor should be, which is in the hospitals, in the clinics, seeing patient after patient. But I had a mentor once tell me and said, you know what? It's great that you can see the Smith family or the Martinez family or the Jones family one by one, and you can make changes that way. But when you're in charge of administration, when you're in charge of policy, you actually can be in charge of changing healthcare for the masses. And that's exactly what Dr. Bonzo Reddick has been doing with his own career, changing for the masses. Because, he may be a visiting professor at this university in the West or up north or down south, and spreading his language and all of his learnings to the next generation of doctors that are out there. But he's also taken another approach to share his knowledge that we're going to get into in just a moment. But Dr. Bonzo, I want to hear a little bit about how your interest in DEI came about, diversity, equity, and inclusion, and what drove you to really do more in that space.
Yeah, so that also was spawned out of my time in public health school as well. I mentioned earlier about how I had that additional certification in health disparities as I kind of incidentally stumbled upon those classes, and it just grew from there, is because when I looked at the public health approach and sort of fixing underlying systemic problems, I realized that so many of these health inequities and health disparities plague certain communities. So it's almost impossible to go through something in healthcare or in health-related fields and not find significant disparities, no matter what you're talking about. If you have an interest in cervical cancer screening, then you'll find that lesbian patients are less likely to be screened for cervical cancer and more likely to die from it. No matter what it is you look at. You look at chronic diseases and smoke-related illnesses, people living in rural communities are more likely to have worse morbidity and mortality related to those things. So the health disparities just kind of started to take over from there. And when you get excited about these things, you start to see, like you mentioned just now, a little more bang for your buck sometimes, that even though it doesn't maybe emotionally feel the same way as delivering a baby, if you're doing something that helps address maternal mortality, that can be just equally fulfilling as well. And sometimes again, a little more efficient as well. So I just kind of really started getting more and more pulled towards, again, the public health and fixing underlying systemic problems. But I also was excited about sharing this message with other people. So I started just kind of wanting to tell people about all the different things I'd been sort of learning. And then, of course, studying after that, I finished, I think, my final coursework in my grad school around 2007, if I'm not mistaken, or maybe 2008 or so. And from there, spent about 2 years just sort of perfecting my message, studying the things I'd already seen, seeing how it contradicted with what I learned in medical school in some degrees or in residency in some cases, and just really digging through it. And then really started to feel confident about the message and about the way we should change up the way we practice medicine. So I started wanting to just share that message more and more. And I actually created a curriculum that I piloted to teach our residents and medical students about different things related to health disparities, health equity, diversity, and inclusion as well. And so that's kind of where it started. And then our medical school started an inaugural associate dean of diversity, equity, and inclusion position. And I applied for that job and was very fortunate to be named as associate dean of diversity. And I did that job for 6 years.
Wow. Yeah, you see how that works, fire starters. You can take your interest, take your gifts, and turn them into the career that you would like. And sometimes you have to ask. Sometimes you have to look for it. Sometimes it has to be created for you. Mm-hmm. But that is why you continue to push forward and achieve and know what you want out of life so that you can get the things that you deserve. Mm-hmm. Now, go ahead, Dr. Bonzo.
Oh, I'm sorry to interrupt. Yeah, because you just reminded me of something. So the first time you and I ever met was when I was going through one of those transitions you're talking about. And I always said for so many years, man, I really would like to spend more time, doing grants or HIV prevention or health disparities. I really wish I could spend more time on it, but I was so busy doing other things. So I delivered babies for about 17 years, which is not super common for a family physician. That's usually more OBGYNs or midwives. But at one point, I was actually the only family physician in our county that was delivering babies, and started a kind of reinvigorated our obstetrics program for our family medicine residency. And so I was doing things like that were so busy. I was taking call. I was teaching a board review curriculum for our family medicine residents. And so during all that, it was difficult to really spend a lot of time on public health. It was more something that just kind of kept creeping up, like I said earlier. And it was actually kind of involuntary that our hospital system was bought by a for-profit, and we were never able to get on the same page about all the nonprofit and what they kind of felt like was almost volunteer work that was happening. And so we eventually had to part ways, and it wasn't something that I really planned on. It would kind of happen sort of over the course of a year, but then it kind of ended pretty suddenly where it was just like, we just can't come to a kind of an agreement about how this is going to work out. And so just like that, in a matter of, a couple of days, it was like, you're not going to deliver babies anymore. You're not going to do inpatient in our hospital anymore. You're not going to teach the residents in their didactics anymore. The residents still rotate with me in my homeless clinic, but me kind of being a mainstay of the residency program, a core faculty member, delivering babies, inpatient medicine, all that was gone. And I was really just kind of wandering aimlessly, like, what in the world happened? I was pretty down about it. But, in talking to you about that a lot, we had a lot of conversations about it. And, really realized that, anytime something like that happens, that means another opportunity is around the corner. And all those things that I was doing sort of part-time that I was like, wow, if I had more time, I would really develop these things. All those things got developed. So like what you're saying is really rings true to me for sure. And I kind of echo what you're saying, that when those things happen, either voluntarily or involuntarily, that's an opportunity that things that you have that you've been wanting to do or meaning to do, or that is really meaningful for you. Those are opportunities to really, really take them and just run with it.
Take a pause. Look and don't say, oh my goodness, things are falling apart. They were never going in this direction. This may be the space that you needed so that you can have that intention to create, the space to think, the space to actually do something to get you to that next level. And Dr. Bonzo, hats off to you for understanding that and creating that for your own life. Now, I want to get into talking about your brand new #1 best-selling book. So congratulations on being a #1 best-selling author, Dr. Bonzo.
Thank you, sir. Thank you very much. I appreciate it.
But your brand new book is called Health Equity, A Guide to Clinicians, Medical Educators, and Healthcare Organizations. And it's out. It's available now. You can get it anywhere you want to buy books. And we are going to talk about health equity right after we finish thanking our sponsors.
This is Super Bowl champion Mike Logan, and you are listening to Licensed to Live.
The time is now to refresh your career. We help doctors, lawyers, executives, and VIPs refresh and restart. Dr. Jarrett's coaching helps you build confidence, gain more credibility, develop more leadership skills, and gain clarity in your career path. Want to climb the executive ladder or branch out on your own? We'll put your career in overdrive. Visit drjarrett.com and sign up for your free strategy session.
Fire starters, this is for you. It's that simple. Time with drjarrett.com. You get direct access to my calendar, set up your free 30-minute strategy session, and you won't believe the changes that will occur in your life just from taking 30 minutes of your time and creating a plan for you. So anytime, set up a meeting with me, timewithdrjarrett.com. Welcome back to License to Live. We are here with Dr. Bonzo Reddick, an excellent educator, an academic physician, a family medicine physician, an administrator, and a public health official, DEI expert, health equity expert. He's a family medicine doc that spent well over a decade delivering babies. All of these Superman qualities of Dr. Bonzo Reddick that he's been dripping out to us all throughout this episode. I have been waiting for this book to come out because you have taught from university to university all across the country, and we finally get to have a little bit of your knowledge that we can learn more about health equity and take it along our journeys to practicing better care. Dr. Bonzo, what made you think about writing this book in the first place?
Well, you actually were partly responsible for that. So you know the answer to that one. So, but I'll take you were kind of the second step. The first step was and I'll get to that in a minute, but the first step was actually me sharing that message. So the funny thing is actually parallels a lot of what we're seeing in society right now. So there's this, if you just Google, CNN or MSNBC or Fox News and type in DEI, you'll get all these articles about this DEI controversy, about diversity, equity, and inclusion. Is it divisive and blah, blah, blah. And when I first started talking about these topics, like I mentioned to you, that I was so excited and wanted to share them with people, I did get pushback from a lot of folks in my own institution. And there were people who said, I feel like you're trying to make us feel bad, or you're trying to make me say I'm a racist, or that I'm sexist, or that I'm homophobic, or whatever. And that's not true. And if we would just stop talking about racism, it would go away. Those are the kind of messages I heard. And sometimes people were quite angry. I mentioned this, I think, in chapter 4 of my book about one of the specific incidences that happened. And there were some changes we were trying to make to the curriculum where we were able to teach these concepts to our students. And that process got delayed by a couple years, actually, because there was so much conflict when we were talking about these things.
Wow.
So instead of giving up, though, what I did was just kind of retool the message, kind of see what things worked, what kind of things didn't work, what kind of messages that people receive or laugh at, and kind of take the sting away from these controversial or sensitive topics. And I'm not perfect, but I think I did kind of get closer to perfecting the message. And what I found was that sort of a blend of kind of almost like humor and just a really light atmosphere to start out the talk really surprised people. So it was like, oh, he's here to talk about racism in medicine. Oh my gosh. And I lead it with a joke, and where I would often poke fun at myself, because one of the concepts of health inequities is that not that there's one specific group of people that do everything, but that we all contribute to a system that leads to these inequities. So each of us on any given day have the opportunity to create these inequities, even for the members that we're a group of, any groups that we're a part of, excuse me. So if you're a gay man, there's a chance that you may do certain things that actually contribute to systemic inequities against gay men. or that you might stereotype another gay man. Same thing for me as a black male. I might stereotype a black male sometimes. There's actually a comment in the book about a time I did that. So I think that's in chapter 3. So what I found was the more I did that, the more it would take people off guard. They were like, oh, I thought he was here to preach at us and wave his finger. He's poking fun at himself right now. But by poking fun at myself, it would show, look how I made this mistake. You all make this mistake as well. Let me show you what impact it has on people's health. And then that's when I would come with the actual hardcore data. And then it would get people's attention. It was data that you can't really argue against, And so, and again, you do the message, you do it certain kinds of ways, you get feedback from people, you find out what things really relay the message effectively, which things don't. You adjust the talks, and then you hit it with okay, we start out lighthearted, we went to data and facts. Let's get serious now and talk about why this is important, why we have to change the system. And by that point, I noticed that was a lot easier than my old way of doing it, which was, we need to make these systemic changes. You're killing people, and kind of more in that kind of way.
Right.
Which, when you're upset about history and that we've had, it's natural to be that way. But sometimes the way you relay that message is important. Now, there's always going to be people that are going to be intentionally distort your message and try to just create havoc. Some people get, thrive off that, or they financially benefit from that. But most people, when you present it that way, the majority of people are open. And some of the same people that used to fight against me in the institution when I initially tried to present this information, when I kind of fine-tuned my message, I noticed that it was well received by a lot of the same people who I've even had literally executives come up to me later on and apologize for how they had received my message in previous years and said, I don't know why I wasn't ready to hear that message before, but I hear what you're saying now. Let's make these changes. So that's a long-winded way of giving you the backdrop about how I made the message a little more palatable for everybody that receives it.
Yeah.
And so when that happened, I started getting a lot more, hey, I heard you gave a talk that was really good. Why don't you come here and give the talk? I started a consulting service where I started doing that, going around and giving talks and advising and consulting on how to achieve health equity in various places. And then, what happened? You go to Florida and give a talk, and then somebody's in the audience who has a friend in Texas, and they say, why don't you come over to Texas and give a talk? And then you give there. And then somebody in the audience works for the government, for the Health and Human Services, and they say, we have a conference. Can you come speak at that? And then somebody from Kansas knows them, and it just kind of spiraled from there. So when I talked to you about this one day, when it really started getting, taking off, this kind of consulting process, I developed 12 different themes that I talk about with health equity. And, you kind of mentioned, well, if somebody comes and gets you for a talk, they only get that one theme. And it's kind of an abbreviated short version of it. Why not write a book? And that way people can get access to all 12 themes. And I kind of joked around, laughed it off. And then you said, when I kind of mentioned about the 12 themes again one day, you were kind of like, sounds like a book to me. So, you kind of would say things like that. And then finally, the thing that you said, it was a great idea. This is maybe an idea for anybody who wants to write a book. You have to just start. You'll never do it if you don't start. It'll seem like an just impossible thing to do. It seems overwhelming, but just start. And the way you had me start was, you were like, you got PowerPoints of all these talks. Why don't you just copy and paste the PowerPoints into a Word document? Which I did. And when I did it for all my 12 talks, the Word document was 75 pages long.
Yeah.
And I said, my goodness, like, this really does sound like a book, doesn't it?
And that's it. It can be that simple, Dr. Bonzo. It really can. And thank you for encouraging the fire starters out there, because there's nothing like taking action. And you said, I'm going to write this book. I am going to do it. And okay, well, if I'm just going to clip these presentations together and see what it looks like, that's a great start. And you continue to develop it from there. And there's so many things that I like about this book and what makes it more unique book in health equity. And I've, contributed to books and read lots of books in this subject matter. But, and actually of note, everybody out there, I want you guys to get a copy of this book anywhere you get it on books. And Dr. Bonzo, do you have a site where they can get the health equity book?
Yes, and the easy way, if you don't have to deal with usernames and passwords and all that, you can just easily go to bonzobook.com and you can purchase directly from there. So bonzobook.com, bonzobook.com.
So you can go to bonzobook.com and get a copy of this book. Now, full disclosure, I wrote the foreword in this book. I was honored and thrilled to be a part of this work for Dr. Reddick. And that's my only disclosure. One of the things that I like is the way you teach these themes throughout this book, Dr. Bonzo. Particularly, you take it from a frame in which you're taking people into your own mind and your own thoughts about everyday issues that maybe many of us have and maybe have thought about and maybe led us to the wrong conclusion. And you do that with every chapter. So tell us a little bit about what we can look forward to reading each one of these chapters.
Sure. So, and this one thing that's been nice is that some of the things I mentioned, where I mentioned poking fun at myself, I do that with each chapter. And when I did it for our medical students and our residents, it was kind of a joke because it was a monthly curriculum at the time. And so, over 12 months, you do it over the course of a year. We kind of called these the bungles of the month. Kind of like when Bonzo would mess up, like, what's the bungle of the month this month? Like, what are you going to tell us about how you mess up this topic? Oh, it's about, sexism in medicine. Like, so tell us about it. What's the bungle where you were sexist one day? Tell us about it. So the students and residents would get excited about it. But what I found that did was, again, it lightens the atmosphere when we talk about it. So there's less of that defensive posture or the anger or the, oh, you're here to try to make me feel bad. No, I'm admitting I do the same exact thing I'm saying that we all do. So the book is constructed the same way. Each chapter starts out with the bungle of the month, doing the 12 middle chapters. There's an introduction and a conclusion that doesn't have a bungle, but the ones in the 12 in between have one. And some of the bungles are not necessarily healthcare related. Like one of them, in one of the chapters on people with disabilities, I actually mentioned about a time where I made an assumption about somebody because they were driving a car that had a handicap placard on it. And my assumption was very, very wrong. You can read the book if you want to find out the exact story, which is kind of embarrassing. But chapter 10 tells you more about that if you want to check it out. But those are examples. So the one thing that's been nice about that is that there have actually been several people who've actually gotten the book, and they're not even in healthcare. But because of that kind of beginning of each chapter, it shows, if I want to give an example about how we systemically create disadvantages for people who are disabled or differently abled, you can actually read that chapter and explains it. If you don't understand bias and you kind of, always conflate bias with racism, you don't understand the difference. And every time you hear about bias, it seems to you that they're trying to make you feel bad or saying that everybody's racist, or you're getting kind of this messaging that. The book, I think, does a good job of explaining that. It's saying, this is what it means. Let me show you examples about how it plays out in real life. And the examples are my own examples. So, and it shows that even people who are the so-called experts, we all make these mistakes and we're all responsible for fixing the system that will undo these mistakes.
There we go. We all have our responsibility. So the more we can learn, the more we can have these discussions, the more we help each other, and the better everything gets. You heard it right from Dr. Bonzo right here on License to Live. Dr. Bonzo, again, congratulations on your best-selling book. And thank you for being a guest here. We've been waiting to have you on the show for such a long time, and to celebrate you becoming a #1 best-selling author with the launch of your new book, Health Equity, a guide for clinicians, medical educators, and healthcare organizations. And here we are today. So do you have anything else that you would like to tell our audience today?
I just want to thank you again for having me on. Thank you for that early motivation and I wouldn't say nudge, but it was more of a shove to write this book. And I'm glad I did it. But yeah, hopefully everybody will check it out and give me your honest feedback about it. Reach out to me on my website and let me know your thoughts about it. And I'm really excited about it. I think this is a much needed book right now because there is so much controversy about DEI and this idea that it's divisive and that it makes people feel bad, when there's a book that presents it in a non-threatening way, but that also still talks about the meat and potatoes of this is something that does kill people. When these health inequities actually lead to significant morbidity and mortality, and we have to fix the underlying systemic issues that cause these disparities. So if you want to learn more about that, then please check out bonzobook.com and hope you enjoy it.
That's awesome. And this is what it's about. It's about bringing this higher level of enlightenment and understanding and conversation, and just maybe taking a different lens at the way we look at DEI. So thanks again, Dr. Bonzo. Where can people find out more about you?
So more about me, I'm on just about every social media app you can think about. So every one of them, my name is Dr. Bonzo with the word doctor spelled out. So DoctorBonzo. That's on Facebook or Instagram or Twitter or whatever you like to use. And you can also go to my website, which is just drbonzo.com. Again, with the word doctor spelled out, drbonzo.com.
Great. Well, check out Dr. Bonzo on social media or anywhere at Dr. Bonzo. Fire starters, listen, we've had another great episode. And if you or anyone you know has been disengaged, dissatisfied, disenfranchised with their jobs, invite them to join us along this journey. Simply go to your favorite podcast player and subscribe to License to Live. And once you're there, rate this episode, give us feedback, let us know what you want to hear about so we continue to bring you the most information about career challenges and life changes. Hey, and I'm hanging out all over social media in between episodes. If you want to check me out on LinkedIn, do that. You can catch me anywhere at Dr. Jarrett, spell out the word doctor, J-A, 2 R's, E, 1 T. And I will see you next time.
No matter how disheartening the moment of accusation sounds, how deep the pain of immobilization stabs, or how bleak your future looks, no one can take away your license to live. Keep Dr. Jarrett's expertise handy and unlock your future. Go to Apple Podcasts, Google Podcasts, or another podcast player and subscribe right now to Licensed to Live. See you next time.